So I want to welcome everybody. Thanks all of you for joining us from so many places. Very exciting to see someone from Paraguay and all over the United States and perhaps other places as well. So thank you so much, everybody. This presentation is about the evolution of COVID-19 and moving treatment to the primary care setting. So we're in an interesting place now in our relationship with COVID-19, our ongoing relationship, where a good deal of the care that was previously being taken care of in urgent care settings like hospitals is now moving to the primary care setting. So we're going to be talking a lot about what that will mean and how to manage and treat COVID in that setting. So we're joined today by Dr. Trinidad Solis, who is from the Fresno County Department of Health and also works in quite a bit in the community in Fresno, and she can tell you a bit more about her work, but we're really pleased to be joined by her. And then we were going to have Dr. Laszlo Medeiros, who is MCN's medical director, but he's actually currently traveling and he's in Ireland and there's a storm in Ireland and he was unable to join us. So we are lucky to have a deep bench and we're joined by MCN's founding medical director, Ed Zara-Westy, who's going to be speaking in Dr. Medeiros' place. I also want to say this webinar is co-presented by the National Hispanic Medical Association and the Migrant Clinicians Network. None of us have any relevant financial relationships that relate to the presentation, nor do we have financial relationships with ineligible companies that are related to this area. On the simultaneous interpretation, if you haven't already done so, you will see there's a globe icon and you can choose English or Spanish. We also have now started to offer our slides in both English and Spanish. So when you go to, and I should have said this initially, apologies for not doing that, but when you go to you can see the sharing options, you can choose whose screen you want to view. My screen, Jillian Hopewell, is in English, and then Karina Gonzalez, her screen has the slides in Spanish. And let us know if you have any questions about either of those things. You can put that in the chat. We're happy to provide you with any sort of technical assistance you need in either the simultaneous interpretation or choosing the slides that you want to see. Okay. As Martha mentioned, this is accredited for both nursing education as well as medical education. We are also happy to provide a certificate of attendance. In order to claim credit for any of those three things, you must submit a post-session evaluation. Just briefly about the Migrant Clinicians Network, for those of you who are not familiar with us, our mission is to create practical solutions at the intersection of vulnerability, migration, and health. We function very much within both the community and the primary healthcare sphere. And then the National Hispanic Medical Association is an association that represents over 50,000 licensed Hispanic physicians across the United States. And their mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanic and other underserved populations. So now I'm going to turn it over to Ed, who's going to provide the foundation, kind of the groundwork of where we're going to go. And then he will turn that to Dr. Solis after just a couple slides, and then we'll come back to Ed towards the end.
All right, Jillian, thank you very much. And for those of you who were expecting to see Dr. Laszlo Medeiros, I'm sorry for your disappointment. But as Jill mentioned, he's stuck on the coast of Galway, Ireland. I know we're all crying our eyes out. So I'm going to step in for him. And the difference between he and I is that he's much younger than I am. We're both family doctors. And we both practiced in the same hospital. I practiced in the same hospital he's in now for about 20 years, but he's a hospitalist. And so he's a family doctor that was in a community health center, but then moved into the hospitalist realm. And for the last 3 years during COVID, he and his partners have hospitalized over 2,000 COVID patients in rural Pennsylvania. So these are his slides, and I'm just going to present his slides for him. And this is his experience. Although he and I have discussed this greatly, so I understand exactly what he's talking about. So he put this slide up first, I think, to just show how a lot of us feel and have felt for the past 3 years. And that is, each time we seem like we're trying to get ahead or move up, COVID has been pulling us down. COVID's been like an anchor around our neck, anchor around our feet, anchor around our arms. And we feel like we've just been pulled down by COVID. So we're going to set the scene here about where we were with COVID and where we're going with COVID. So what we knew then and what we know now. So in the very beginning, when he would hospitalize somebody, they felt like early intubation was an important thing to do. But now, as time's gone on, they realize that they try to avoid intubation as long as possible. Also, in the beginning, they were using steroids very early in the COVID serious cases. But now they're really reserving the steroids for hospitalized hypoxic patients, people that aren't getting enough oxygen. And he also viewed what he terms happy hypoxics. And these are people that he would go up to them and say, hey, how you're doing? And they're saying, oh, I'm feeling fine. And their pulse ox would be in the 60s or 70s. They'd be very hypoxic, but seem to be fine. Now they don't wait for them to get that far along. They're starting to use oxygen and BiPAP early on in the hospitalization of people before they become very hypoxic. They also were using a lot of convalescent plasma in the beginning. This is plasma that they got from patients who had recovered from COVID, but they're no longer using this regimen. So things have really changed. And that always confuses the public when we say, this is important, and then a few months later we say, well, that's not important anymore. But that's the way science works. We learn from our mistakes, or we learn from our experience, and then we change tactics as time goes on. So here's some other things that we knew then, what we thought then. We thought that the vaccination, when it came out, it was going to prevent a lot of COVID cases. But now we realize it doesn't really prevent cases very well. It does in the beginning, in the first few weeks after you get a vaccine, you're less likely to get infected. But now we're really relying on the vaccines to prevent hospitalizations and especially to prevent deaths. And that's a great thing about a vaccine. If a vaccine can prevent hospitalizations and prevent deaths, then it's a very valuable tool. Also, in the beginning, it was mainly respiratory. Most of the patients coming in the hospital were complaining of respiratory problems. But now, hospitalized patients are not only complaining about respiratory problems, but also a lot of them are presenting with gastrointestinal or vascular problems. So that has changed with the patients that are coming into the hospital that Dr. Medeiros is seeing now. Also, we thought in the beginning that you got COVID and then you got over it, and then a week or 10 days or 2 weeks later, it was over. It was the end, right? We thought it had a definitive beginning and a definitive end. But now we realize that COVID can go on for a long time, weeks, months, and maybe even years. So now that's called long haul COVID. And we're going to talk about that in detail towards the end here. And so now, Jill, I think it's time for you to turn it over to Dr. Trinidad.
Yeah, to Dr. Solis. Yep. So now, yeah, and Dr. Solis, if you wouldn't mind giving a bit of a background of your experience, and then move into your slides.
Well, hello, everyone. So my name is Dr. Trinidad Solis. I'm also a family medicine physician. And so during the pandemic, I've been seeing patients at a federally qualified health center in Fresno County. And for those who are not familiar, Fresno County is the largest county in Central California. And also in January of 2022, I was promoted to deputy health officer in the Fresno County Department of Public Health. And so my role role at the health department involves providing developing like health advisories for the local physicians in our county. I also provide consultation to different divisions within the department, helping with outbreaks responses, not only COVID, but as we've been seeing during the last few years, we've also seen monkeypox and other infectious diseases that we really hadn't seen before in our region and also in the US. So yeah, I played different roles. And today I wanted to talk to you all about, today I wanted to talk to you all about COVID treatments, how we can do a better job in the primary care setting of not only as physicians prescribing it, but also educating the public more about the COVID treatments, because they have been shown to reduce hospitalizations and death from COVID. But before I get to the COVID treatments, I did want to spend 1 or 2 minutes about the COVID vaccines. As Dr. Ed was talking about, that the vaccines really, we rely on them to prevent COVID, serious complications from COVID infection. And so we've been promoting not only here in Fresno County, but the Department of Health and Human Services has also launched a campaign. I'm also involved with the National Hispanic Medical Association. They have a large national vaccination campaign, really letting the public know about the boosters. And as Dr. Ed was saying, you know, we've had, we started with the primary vaccine series, we've gone through different boosters, and now we have this latest updated booster known as the bivalent vaccine, and it protects against the original strain of COVID and the Omicron subvariants BA4 and BA5. BA4, BA5 last year were considered dominant, and now we have new variants, for example, XBB, in the XBB family, which all really are descendants of the Omicron subvariant. So the virus continues to change and mutate, and really the scientists at CDC and so forth are developing boosters to really try to offer us the latest protection. And that's why it's very important to promote this to our patients and to the public to get the booster. Right now, everyone who's 6 months and older is eligible to get this updated booster, and it can be administered at least 2 months after you finish your primary series or last booster dose. Next slide. And so I wanted to highlight, this was a new change that happened about 2 weeks ago. So this is why I wanted everyone to know that for children 6 months to 5 years, for Pfizer, before they were saying, the FDA, for example, was saying if someone already completed the 3-dose series of the Pfizer primary series, then they're not eligible for the booster dose. But since then, the FDA has done some clinical trials, and now the new update is that now children who've completed the 3-dose primary series can now get a booster, this updated booster, 2 months after they after they completed that primary series. So same with Moderna, if you completed the 2-dose primary series, you can get that booster. But I just wanted to let everyone know that is a new change that came out about 2 weeks ago. And myself as a family medicine doctor, I treat it as a vital signs, and last year, I was precepting also at the local family medicine residency clinic, and I would teach the residents, treat it like a vital sign. So for example, if someone comes in for their well child check and they're 5 months, so they may not even be eligible, but I ask the parents, are you vaccinated? Because that way they can offer protection to their baby. And a lot of good discussions come out of that. Sometimes I hear concerns from the parents. Sometimes I hear misinformation or myths that they heard, and that's why they're not wanting to get vaccinated. I saw that a lot in pregnant moms concerned about, oh, they're going to pass on the virus to the baby through breastfeeding. So a lot of myths. So I always encouraged my residents when I would teach them, and also myself, even if they came for something else, I always checked off and made sure I at least had that discussion with the patients or their families or parents. Next slide. Nope. Yes, and this is just another visual of what I was just saying right now. I'm a very visual learner. So for me, I had this in the clinic charting room. So I know there's some physicians and community health workers. So I know this is a diverse group, but I'll share the link to this chart for whoever wants it. I feel like I found this very helpful. It's color coded also based off the vaccine, because the vaccines, the top are color-coded based off age, and it also shows you when the doses are due. So again, I'll share this resource, the link to this afterwards, but I wanted to highlight for me, because as Dr. was saying, science is changing, the vaccine schedule changes as we learn more information from clinical studies. It's always good as primary care doctors or community health workers to know what's the latest on the vaccine schedule. I also wanted to clarify, I gave a talk last week and majority of the audience was above 65 years old. And a lot of the patients were asking me, well, I already got my first dose. They were above 50. So just to refresh everyone's memory. So in the past, if you're over 50, you were advised to get your first dose and then second booster, and then the updated booster. So I was getting questions when are they do they have to finish those 2 booster doses in order to get the bivalent? So again, now the latest guidance here is if you've completed your primary series, you can get that bivalent booster. You don't have to go in that sequential, okay, first booster, second, and then this bivalent booster. So I wanted to clarify that because that's a question I get a lot, and you may get that when you're out in the community as a health worker, community health worker educating, or as a primary care doctor. And again, it's always, I can share this resource here if you find it helpful for yourself. Next slide. So I'm going to switch gears here and move from vaccines to treatments. And I always encourage patients to have a plan. So the best way to prevent COVID is getting vaccinated. But if you do have COVID or get infected with COVID, have a plan. And so the reason why I'm spending time today and us here, we're having this webinar and trying to improve access to treatments is that research is showing that racial and ethnic disparities exist for outpatient COVID treatments. And so I wanted to highlight this study. Came out from the CDC, and there you can see the authors there, but it was titled Disparities in Outpatient Treatment of COVID-19. And it was from January to July 2022. And during the study, they surveyed over 700,000 patients in 30 different clinics throughout the US. And majority of these patients were above 20 years old. And during this time period, as you saw from April to July 2022, they were mainly looking at Paxlovid use. They mentioned here that patients aged 20 years who were treated with Paxlovid, it was 36% lower among Black patients relative to white patients, and 30% lower among Hispanic patients relative to non-Hispanic patients. And the authors here mentioned there could be several reasons for this. There could be language barriers, there could be transportation issues, but they also mentioned it could be an issue of education, not only from the providers, but also from the patients. And so that's why for this webinar, one of my objectives is to help increase that education, because sometimes educating not only the providers, but also the public can really help improve these racial and ethnic disparities that are occurring with outpatient treatment. Next slide. So here I wanted to go over currently what are the outpatient treatments for COVID that are offered in the public. And this is based off NIH. They have a COVID-19 treatment guidelines panel, and they list in order of preference, and also based off, again, it says clinical studies and the effectiveness. And as you can see, before I go on, so in the past few months, because of COVID virus changing and variants and resistance, we no longer have monoclonal antibodies on here. And we also don't have Evusheld, which was used to prevent for someone who was exposed and who was immunocompromised. It was used to help prevent infection. So those are no longer available due to resistance because of the latest Omicron variants. So that is something important to know, because I often get that question, oh, hey, doctor, should I get the monoclonal antibodies? But it's actually not available at this time. So really, the first one that the NIH panel recommends is Paxlovid. It's close to 89% effective at reducing hospitalization and death. And then the second one is remdesivir. So so remdesivir is an IV infusion and it's given over 3 days. But because it's given over 3 days, and again, it's an outpatient. So the person goes, gets an infusion, goes home, then comes back the second day and then goes home. And so it's very difficult from a provider and patient standpoint to come back like 3 times and make that happen. So for example, in my county where I practice here in Fresno County, we don't have an outpatient provider offering this. And we're the biggest county in Central California. So we really rely more on the oral antiviral, so the Paxlovid and the molnupiravir. So just keep that in mind as a provider, that really the Paxlovid is more easier to administer or prescribe if it's not contraindicated in a patient. But so Paxlovid, remdesivir, and then the NIH panel says if for some reason the patient, there's a contraindication or they can't use the first 2 therapies, then they can try the molnupiravir if they're eligible for that. Next slide. So I'm going to talk a bit more about the oral antiviral treatments. So there is a federal agency known as Administration for Strategic Preparedness and Response, known as ASPR. And for those who may not be familiar, they have a program called the Test to Treat program, where an individual, if they have symptoms, they can go, COVID symptoms, they can go and get tested. And if they're positive, they'll be evaluated by a provider. And if there's no contraindications or any concerns, then they can get their medication right then and there. So if part of this program, they offer oral antiviral treatment. So the Paxlovid, as I was talking about, or molnupiravir. I do want to pause here and just let our providers on the call know that if your clinic is currently not part of the Test to Treat program, that is something to consider. Perhaps talk to your leadership. We have clinic medical officers, for example, reach out to us at the health department, and then we help them through the process of becoming a Test to Treat program. So even though it's federal, sometimes your local health departments can offer you support. And it's really helpful, especially for example, if you're in a rural area and it can be difficult for a patient to go to a pharmacy where now, if you're part of the Test to Treat program, they can get medication right then and there if you were to prescribe it. So something to keep in mind if your clinic currently right now is not a Test to Treat program. We also have, so I wanted to just talk a little bit more about Paxlovid. Again, it's for 12 years and older, at least 88 pounds. It's really 3 pills given. It's 2 medications, but it comes in 3 pills given twice a day for 5 days. And then you have molnupiravir. Again, this was second-line agent if for some reason someone cannot take Paxlovid, and this is for 18 and older, and avoiding pregnancy for molnupiravir. And very important, again, we tell patients, if you're having symptoms, stay home, get tested. If you're positive, talk to your doctor, because really it's most effective when it's within the first 5 days. And then here is a list from the CDC about who is considered high risk, because the studies show that Paxlovid or molnupiravir, these treatments are very effective in individuals who are at high risk of developing COVID complications. So for example, if they're age 50 and older, if they have cancer, chronic kidney, liver, or lung disease, diabetes, obesity, heart conditions, immunocompromised. So again, a lot of members in our community fit in these categories, and especially in communities like Hispanic communities where diabetes is very elevated. So again, as a primary care doctor, if someone comes to your office, very important to keep this in mind. And also if you're a community health worker, educating the public about who's at risk. And right now, when looking at the CDC death data of who's actually dying from COVID right now, it really increases with age. So CDC says here like 50, but if you look at the trends, 50 and then compared to 60 and then 70 year olds, unfortunately the death rates keep climbing. And again, with immunocompromised. And now that we don't have that medication Evusheld, it's very important to think about this. So as a primary care doctor, I highly advise our providers on the call, especially if you have a patient, if it's older age, immunocompromised, very important to consider treating them. And a lot of times if they're immunocompromised, you likely will need to work with their specialist in case they are taking, or they're on chemotherapy, if they have cancer or other issues like that. Next slide.
Can I just pause for a second, Dr. Solis? And there's a couple questions that have come in. Do you want to wait towards the end and answer questions, or do you want?
I can wait towards the end.
Okay,
Yeah, I think I just have like a few more minutes and then, happy to. So another point to consider, again, as this is more for our providers on the call, about when prescribing oral antiviral treatments. I know when I've spoken, because I sometimes participate in meetings with our federally qualified health centers here in Fresno County, and we hear feedback from our providers, and they mentioned there's hesitation to prescribe because with, for example, Paxlovid, there are a lot of drug interactions to consider. And so that can be worrisome for some providers. And so this is a tool that I found helpful and that we've shared with our providers. Again, ASPAR is that federal agency that runs a test to treat program, and you can click on their drug interaction checker. And I know as doctors, we have other tools where you can track drug interactions, but this is just one example. And a common one that patients in the primary care setting are on is the statin or cholesterol medication. And so for example, if you want to give someone Paxlovid and they're on the statin, it gives you recommendations on when to hold and so forth. So another common one, the drug interaction is, for example, the blood pressure medication, amlodipine, or a blood thinner, warfarin. So those are common ones as primary care doctors you may run into more often. And again, it'll give you suggestions. Oh, hey, you may want to lower the dose, or hey, you may want to check INR more often if they're on warfarin. But there's some medications where it's contraindicated and you can't go around this. So you may want to go to the next in line after Paxlovid, as we talked about. Again, for those individuals that are immunocompromised, those are the ones you really want to prescribe these treatments with. And that's where you likely will have to work with their specialists, oncologists. That way you both can come up with a plan for these patients. And I also wanted to remind our providers that Paxlovid does come in a renally dosed form. So it's a lower dose for those who have moderate renal or kidney issues, as you can see there. And Paxlovid is not recommended for people with severe renal or hepatic impairment, meaning kidney or liver impairment. And again, I'm spending a lot of time on Paxlovid because it is considered first-line therapy in terms of most effective or antiviral treatment that we have right now. But as we saw, there can be a lot of different drug interactions. And for that reason, a patient may not be eligible. And that's why a provider may turn to use molnupiravir. Next slide. And then again, common side effects. This is a question I get all the time. Hey, what are the side effects? And as a provider, I do want to advise, sharing the most common. I've had a few patients tell me, or when I hear from the community, they didn't take Paxlovid because the doctor read all the lists and it scared them. They're like, oh, forget it. They're not taking it. So it's always important to weigh benefits versus risk as with any medication. But for me, I try to focus on the most common. And so for Paxlovid, for example, the most common is individuals may have a metallic taste in their mouth while they're taking the medicine. Some may have upset stomach, diarrhea for a day or two. But again, COVID can also cause that. So it's hard to tell whether it's a medication or COVID. But again, I do caution that. And then COVID rebound. So studies have shown that a lot of patients don't want to take this because they've heard of COVID rebound. They think it's fairly common. And when I say COVID rebound, that means that individuals so it may occur between 2 and 8 days after initial recovery. And it's characterized by a recurrence of COVID symptoms or a new positive test after you tested negative. At this time, studies show that this is still fairly rare. I think the FDA showed a study where it was 1% where it can occur, but I think as more data is coming out, I think I was reviewing a study last night where it was saying it may be closer to 5%. But this has gotten a lot of attention because, as we saw in the media, President Biden also had COVID rebound. I believe Fauci did. So this, based off different polls, this may be a reason why some patients are hesitant to take it. But studies still show that even if someone were to get a COVID rebound after finishing, for example, Paxlovid, that still reduces their risk because they took the medication. It reduces their risk of being hospitalized or dying from COVID. And even if you didn't take medications, COVID rebound can still occur. So even if someone on their own got COVID, no treatment, and they recover, they can still get rebounded. It can still happen. So I think it's just important to educate the public on that, hey, even without treatment, someone can get rebound, but if you were to get it, it doesn't mean, that it didn't help you. It can still reduce your risk of hospitalization and dying. And if you were to have a patient who has COVID rebound, the current guidance is to advise them to isolate again for another 5 days. And then it depends if their symptoms are improving, they can leave isolation, but really it's to isolate again. And in general, we don't retreat again with more medication. There have been some studies where if someone is immunocompromised, then you may want to treat, but in general, that would be something to be discussed with their specialist. In general, the current guidance from CDC is you don't need to restart treatments, just advise them to isolate. Next slide. And lastly, I wanted to share, so I talked a lot about the medications, but also the importance of sharing information with the public. So as physicians, we can share in our clinic waiting rooms, urgent care, emergency rooms, and the Department of Health and Human Services just came out with some more materials on treatments in English and in Spanish. And that's great because I feel like in the last few years of the pandemic, we've had a lot of emphasis on vaccines, which is great, but we also, I think, need to discuss or let the public know about treatment so they can discuss that with their doctors. And then I know there's some community health workers on the call. We also rely on our community health workers that are trusted messengers in the community to share these educational materials. So I think if we both work together in the not only in the clinic settings and hospitals, but also out in the community, we can really help reduce COVID transmission in our communities. Next slide. Oh, and this is just a summary page that I already pretty much covered about just different overall prevention tips that here at the health department in my region we've been promoting, but really this has been a national message even from CDC about how to prevent COVID and the importance of wearing your mask in crowded public indoor spaces. We've also really been stressing the message, stay home if you're sick, get tested for COVID, and then strategies to promote some prevention and treatment. I think we talked about campaigns, about getting the word out, not only on the clinics, but also through social media and, TV, radio, and leading by example. So by that, I mean, for example, for those on the call here, like not only our health providers, but our community health workers, when we're out and about, or for example, getting your vaccine in public, showing pictures, showing on social media, same with masking, if it's crowded indoor, and, wearing your mask. So things like that. So for me, I found it very helpful that whatever I, message to the community, I also do myself. And I show like, hey, I got my booster and so forth. So again, these are a lot of efforts going around, not only in my region, but I've seen it happen around the country where a lot of community-based organizations working with community clinics to really get the word out on these prevention measures and treatments. Next slide. Oh, and I really quickly wanted to highlight, so here in our county, we realized we have the largest amount of farm workers in the state of California here in Fresno County. And so many could not express that it was hard to leave work to go get their vaccine. So we were one of the first counties in the country where we met the farm workers at their workplace. So we got a mobile clinical partner. We today have administered over 35,000 doses of the COVID vaccines to our farm workers. And there's just a picture of me educating some of the farm workers while they waited in line and answered their questions. And because it was so successful, we decided, next slide, to do a program where now besides COVID vaccines, we're also doing checking for blood glucose, checking for blood pressure, and we're also a COVID test to treat site. So that way, someone in our rural areas, they don't have to drive 30 minutes to a clinic near them for to get, for example, treatment, they can go to a mobile unit. And so our mobile units go to rural areas and they go to agricultural workplaces. And I believe we're one of the first counties in California that not only is offering medical portion here, but we also have community health workers coming to these events, helping linking people who don't have a primary care doctor to a nearby clinic. And they also are asking about some social determinants of health questions, such as food insecurity, housing, and they're working on linking them to nearby resources. So I'll go ahead and I think that's it. Next slide. Okay, that was just a summary slide, which we've already discussed. So yeah, if we can go ahead and end, Jillian, and so I know we have some questions.
Yeah, before we move on back to Ed, who's going to talk some about what long COVID is looking like in the primary care setting, there are some questions that have come in.
Mm-hmm.
So a couple about the bivalent booster. So one person asks, they've been getting a lot of questions lately. If you have received the bivalent booster in October, do they need to get another booster?
Yeah, and that's a great question. So the answer to that is no. So that booster is like a one-time thing. It's not like every 2 months you got to get your booster. So at this time, if they already got, because that booster just came out last fall. So if someone already got it, that's what they need at this time. But again, right now we're doing research because I've gotten the question, well, is it like going to be a once a year thing like the flu vaccine? And at this time, we don't know. So right now we're studying, we're seeing what the latest variants are. So for now, if someone's gotten the latest booster, it's once at this time.
Thank you. And then there's another one. If someone has the first scheme, el esquema primario, and the first booster, can you apply the bivalent?
Yeah, so that means they completed, like they were above 50 and they, I'm assuming, and they got that first booster that came out, then yes, they are due because that first booster wasn't the bivalent version. So this bivalent version just came out last fall. The prior boosters weren't bivalent. So yes, even if they got that first booster over a year ago, if they haven't gotten the one that came out last fall, known as the bivalent, then yes, they would be due for that if it's been more than 2 months.
Okay. Okay, there's a few more questions. So another one is, once you have had COVID, how much time should you wait to get a booster or the vaccine? Yes,
well, in general, CDC advises that you can wait up to 90 days after you've gotten COVID and fully recovered, no symptoms, that you can wait up to 90 days to get your bivalent vaccine. But if an individual, especially if they're high risk, doesn't want to wait 90 days, at the very least, they have to finish the isolation period. So in general, we consider that 10 days. So when someone isolates, they have to continue masking for 10 days. So we usually say about 10 days, and also make sure your symptoms are improving and you should be fever-free for at least 24 hours without medications.
Okay, thank you. So a couple more. Diamond Mosley is asking, in vaccine cases where we see adverse effects such as myocarditis, how do doctors then determine if someone is a good candidate for a vaccine? How then do we mitigate the risks of adverse effects from a vaccine dose?
Right. So that is a concern with the mRNA vaccines, where some individuals did have myocarditis. It's still considered fairly rare, but again, it is considered adverse effect. And we do encourage doctors, if that happens to them, like report it to the CDC. They do have I'm blanking on the name right now, but they do have like an adverse outcome where a doctor can report it on their the website. So that way they keep track. But for an individual, for example, if they've had myocarditis and if they wanted a vaccine, we would recommend, for example, get the Johnson & Johnson that isn't mRNA. But for the booster, right now, the boosters are only mRNA. So I think that would really depend, like that would require a conversation between the patient and the doctor, because it depends on the severity. But in general, in the past, if someone had myocarditis, we would say, okay, maybe try the Johnson & Johnson, because that, or Novavax, so something that's not mRNA would be the recommendation.
Okay, and one final question, and this one may depend on the location where someone is, but is it true that we're beginning to cover the cost of the vaccine for people without medical insurance?
Great question. So that really goes into like end of COVID emergency, what's going to happen. And so we're all on the same page. The federal COVID end of emergency is ending May 11th. And at this time, what they're expecting is that for at least COVID vaccines and treatments, if someone is insured, they are likely not going to have to pay either zero or very little out of pocket. But some states have safety nets. So even if you don't have insurance, there's programs to help those individuals get a vaccine for free. For example, again, in Fresno County, we have this rural mobile health program where it's free. So individuals can go get their vaccine, can go get COVID treatment, but not all states have that. So really it depends on the providers or like community health worker where in your state, like what will happen after May 11th. And that will take some time. So it's not going to be like immediately after May 11th, you have to pay for your vaccine. For the treatments, it's called commercialization, which means it enters the market, and they expect like several months, like at the end of the year, where some people may have to pay some out of pocket if they don't have health insurance. But for testing, that is something that many health insurance companies have already made it clear that they will not pay for free tests anymore. So I do recommend for patients or just the public, right now you can still get free COVID tests from the government, like the website. I believe it's called, and I can put it in the chat in a bit so I can find the exact website. But I've been telling families, hey, stock up. Right now, the federal government is still giving free COVID tests. That way, even after May 11th, they have a few tests in their household in case they need it. But that is one thing that is going to change the COVID test. Many, even if you have insurance, will have to pay some out of pocket.
Thank you. And then just before we move on to the long COVID, another person pointed out that the FDA is going to be making a decision in the next few weeks regarding potentially another dose of the bivalent booster for elderly or the immune compromised, which kind of goes to the point we've been making, which is that things are moving quickly and changing quickly, and that we sort of recognize the challenge that places on all of you in trying to communicate.
Yeah, well, thank you for whoever shared that, because that is helpful to know. And again, I recognize for the providers and community health workers, it is tough to constantly be on top of the changing science and guidelines. But I do commend you all for even being on this call. Because even myself, and as Dr. Ed said, we're all learning, and I'm really excited to be here so we can share strategies on how we can continue to improve and get the message out to our communities.
So I'm going to turn it back to Dr. Zara-Weste to lead us in a brief discussion of long COVID, because that's another big issue, and one that is definitely centered in the primary care setting in many cases. So, Ed, I'll let you take that away.
Okay, just a comment on the last question that came up, Jill. And that's why, for example, in Great Britain and some other European countries, they are now doing that. They're giving the second booster to elderly and high-risk immunocompromised individuals. So that is happening other places in the world. And as was pointed out, the FDA is looking at that now to see if for those high-risk individuals, we may want to give a second bivalent booster. So now, next slide. So now let's talk a little bit, and again, we're not going to go into this in great depth, but we're going to talk about long COVID. What is long COVID? Well, initially we thought, again, that you would get acute COVID. And then depending on the predictors, like demographic factors, like your age or your sex, or your medical comorbidities, like obesity, asthma, diabetes, and how severe your acute COVID was, what your viral load was, and other social determinants, and your vaccine status, all that depended on whether you went to full recovery. And we initially thought that everybody eventually went to full recovery, but now we know that a significant portion of individuals go into this longer COVID episode called long COVID. And it has lots of different names, long haul COVID, lots of different names now. But the way we're seeing it, and some of the proposed contributing mechanisms for why we think some people are going on to low COVID is, we now know that there's some viral antigen persistence. In some people, they're able to find the virus, the COVID virus, for months and months and months after their acute COVID episode. So the virus seems to be lingering, especially in certain parts of the body. And so the question is whether you just have this low-grade infection that's continuing to make you have symptoms. Another proposed mechanism is systemic and tissue-specific inflammation. That the COVID created this inflammation, then your own body continues to have this inflammatory response, and that's creating your symptoms. Or it's also felt that maybe you reactivated some human herpes viruses that were in the body and were quiescent, and now you've reactivated those viruses and they're causing you symptoms. Or dysbiosis, you've disrupted the biome in the gut, and now since that's out of whack, you're having these symptoms. We know that there's some microvascular dysfunction that's occurring. Is that due to inflammation? Is that due to persistent viral antigens? Nobody really knows, but there does appear to be some microvascular dysfunction, and that's leading to symptoms of long COVID. And then there does seem to be, one more thing, Jill, there does seem to be a SARS-CoV-2 specific autoreactive immune response, that the virus itself is creating an autoimmune reaction, and that's giving you symptoms. Okay, next slide. And it can affect all these body parts, okay? The heart, you can have chest pain, myocardial inflammation, increase in your troponin, you can have palpitations, your brain, it's very common to have brain fog, delirium, fatigue, sleep disturbances, depression, anxiety, PTSD. The spleen can have decreased in T and B lymphocytes. You can have atrophy of the lymphoid follicles. In the liver, there can be liver injury. You can have increased enzymes in your liver, your blood vessels. You can have inflammation, vessel damage, coagulopathies, microangiopathies. In the GI tract, you could have persistent diarrhea, nausea, and sore throat. The kidneys can show impairment and acute kidney injuries. The pancreas can show injuries and pancreatitis. And in the lungs, you can have continued dyspnea, chest pain, and cough. So all these organs can be involved in long COVID. Next slide. So what the patients themselves may experience is that acute COVID is now stated to be lasting for the first 3 weeks. And then post-acute COVID is after 3 weeks. So you can have a post-acute COVID and still be considered as part of that COVID. So that long COVID now is defined as beginning 3 months after acute infection. There's no known endpoint. Some of this has gone on from the very beginning. So 2 or 3 years now, people are still symptomatic. And as I mentioned before, it can affect multiple organs, the lungs, the brain, the circulatory system, the heart. Next slide. So what are those characteristics associated with COVID and its sequelae? Well, first, if you go into the social determinants of health, it does seem that there are some characteristics of the individuals that seem to be associated with long COVID. If somebody has substance use, drug or alcohol or tobacco, they seem to be more susceptible to long COVID. The social cultural things, language, culture, religion, government institutions, political instability, stressors. If you're under more anxiety, if you're worried about childcare, elderly care, legal considerations, immigration considerations. If your baseline health is poor, you have other comorbidities, or you have chronic diseases or mental illness. If you have difficulty accessing healthcare because of the costs, or geographic distribution, or the quality or poor data outcomes. If you have housing instability, you're in crowded housing or residential housing, or food deserts, food insecurity, or economically, if you're unemployed or high-risk work, if you're essential worker, so you have to go to work all the time, if you don't have access to protective equipment, if you have transportation problems, food insecurity, these are all those things that can create problems. And then if you go in the outer circle, the structural injustices, the structural racism, the health inequities, all these things can make individuals who have gotten acute COVID more susceptible to long COVID. Next slide. So now we're kind of confused. As Dr. Solis pointed out, as of May 11th, we're ending, right, the COVID emergency, even though 300 people are still dying every day of COVID in the United States. 300 people will die today, they died yesterday, will die tomorrow. That's still an emergency. It, however, because of political reasons and other reasons, economic reasons, we're going to end the emergency, but the emergency is not ending. So now we're kind of, as primary care providers and outreach workers, what do we do now when somebody has COVID? Well, first of all, is the person truly sick? And if so, with what? So somebody comes in, do they have COVID? Do they have the flu? Do they have other viruses that are floating around now? We still have to make the diagnosis. Then you got to get a COVID test. Where are you going to get it? What kind of COVID test? How are you going to find them? Then you got to wait for the results. And sometimes that waiting time is 15 minutes or 2 days. And then if the person is positive today, what are you going to tell the person? Can the person isolate? If they're an adult, they have a lot of decisions. Can they go to work? People are now going to work. Wearing masks. Do they tell their employer? Do they isolate? What about childcare? What about parental care? All these that we had good guidelines before, these guidelines now are not going to be enforced. So we have to, as providers and outreach workers, we have to help people continue to know that you've got to isolate yourself if you have COVID, or you're going to spread it to other people. If a child's positive, how do we isolate that child? Who takes care of that child? How to quickly learn what to do, monitor for serious illness, treat for comfort. Again, as Dr. Solis pointed out, talk to your primary care provider. You may need to have antivirals. You may need to get Paxlovid. When should you call your PCP? When should you go to the urgent care? When should you go to the emergency room? What if the person has underlying medical issues? Which ones matter? All these are still questions that we have that you need to have good answers to, and it's an individual basis with your individual providers. And the outreach workers and the community health workers can help direct individuals to where they can go for those answers. Does the person qualify for treatment, and are they going to have to pay for the treatment now? Steps to get treatment started within the first 5 days. So all these things are now becoming a little more complicated since we're no longer in the emergency. Next slide, please. So again, how many people are really suffering from long COVID? Well, this just came out in the MMWR not long ago, stating that approximately 1 in 5 adults age 18 and older have a health condition that might be related to their previous COVID-19 illness. And again, all those symptoms. Now, this is a moving target. Again, Dr. Solis and I are giving you the facts as we know them as March 28th at about 2:00 p.m. Eastern Time. These recommendations are for right now. They could change next week. They could change next month as we get new data. But right now it's felt that 1 in 5 adults may have health conditions related to long COVID, but it also may be masked by other diseases. So somebody that comes in with cardiac issues, don't assume it's due to COVID. Someone comes in with lung problems, don't assume it's due to their COVID they have. They may have some other issue. So you really have to talk to your healthcare provider if you have symptoms after you have COVID. Next slide. So now we have lack of clarity, and that contributes to the difficult adjustment of what is long COVID, because there's no universal definition. Not many specialized services are around yet, although there's a lot of movement in that direction. Both healthcare workers and family members may greet a person's symptoms with skepticism or frustration due to no clear definition, and protocols need to be established. So that, you have to listen to these people that are coming in with symptoms after they've had COVID and assume that it may be due to the COVID, and don't blow them off, really listen to them and try to figure out what's going on. And there's long wait times for service, even if you live near a health center. Next slide, please. So Jill, I'm going to turn it back over to you for our handouts.
Yeah, so just to round things out, thank you so much to both Dr. Zerwesti and Dr. Solis. I wanted to just highlight a few resources that we have on an ongoing basis. The Migrant Clinicians Network has a frequently asked questions page on our website that's available in both English and Spanish, and we update that very regularly, every couple of weeks, really, with new information that's coming out. So please know that that is a resource for all of you, and the link is there, and you'll be getting this slide deck in both English and Spanish. So thank you. We also have a number of vaccination and other COVID education materials for COVID in the community, and we have those in multiple languages. And the National Hispanic Medical Association also has materials so go to their website. But I just want to highlight that one of the things that we have done as the Migrant Clinicians Network and some of our projects with some other partners is to create fully editable materials and templates so that you can take photos of people in your actual community and insert them into the health education materials and use those. So there's a lot on our website, and we have some manuals and things to help you do that. So I want you to know that that's all available for you. And we have a couple more minutes for questions. I'm going to put up the evaluation link, but and it will also come to you afterwards, but you can follow the QR code and do it through that as well. But and a link will come afterwards. But we have a couple more minutes for questions. If you have anything for either Dr. Solis or Dr. Zerwesti. And I also want you to know that we're going to be doing more webinars coming. We'll have one every month on a COVID related topic, COVID in the primary care setting. So we're going to be addressing misinformation. We're going to be taking a greater look at long COVID. We will also be doing some additional work on the intersection of mental health and COVID, looking at the workplace and COVID setting, how to set things up. So there's a lot of things coming up. I encourage you to take advantage of those. And then we still have like another minute or two for questions if anyone is typing them in. I had a question, Dr. Solis, you had talked about the, oh my gosh, I can't remember the name of it now, but the way to tell, the link to tell whether you're in the program that can get you some free services for your patients.
Yeah, the COVID, I think someone I saw put it in the chat for.
Oh, they did? Okay, great. The COVID test, or no, I was thinking of the, oh my gosh, I'm so sorry. I need to go back to the slides here. Actually, I can go back to this one. Oh, the Test to Treat program. Is that a health department program or is that a federal program?
Yeah, so that is a federal program, and it's it can be like clinics out in either metropolitan or rural, but it's all federal. So someone can you can look up Asper Test to Treat, and then they have like a zip code. Someone can enter their zip code and they can find where the nearest Test to Treat site is near them.
Okay.
So I can try to find that link, Jillian, and then.
Okay, that'd be great. And then we also have a couple of questions about long COVID. So one of them is, what would you be your best advice for primary care providers to help patients with long COVID when there aren't many treatment protocols and long wait times at specialist clinics?
I can take that. There are a lot of symptomatic things that people are doing now, physical therapy, mental health help. So you treat the symptoms the way primary care folks do all the time. So you go to your primary care provider and tell them your symptoms, and primary care providers should do the best they can of treating the actual symptoms the person is suffering from. And there was another one, Jillian, that do you have any data on individuals who have recovered from their long COVID symptoms? I don't have any data on that, Dr. Solis. I don't know if you do. I think we're still looking for those cohorts of people that are suffering from long COVID. And so I'm not aware of any good reports yet of the cohort of people who have fully recovered from their long COVID and what sort of treatment they had or what sorts of things created their recovery. But maybe Dr. Solis does.
I agree, Dr. Ed. I'm not familiar with any recent reports, but as primary care doctors, a lot of us, like you mentioned, treat the symptoms, but there are certain, it's more like metropolitan cities where they're having long COVID clinics. So there's like specialists that work together and are trying to do more research and learn more about it. But I know in California, they have some UC campuses where they're working together with the state health department to have COVID clinics and do that. So in my region, we don't have a COVID clinic. So it's more the primary care doctors treating the symptoms, but that is something to look in your region. Cause I know this is a lot of big cities are starting to do that. I know it's in New York City. I've seen a few long COVID clinics. And again, like some of our San Francisco, Los Angeles have them. So that's another option to look into. But for the most part, as you mentioned, Dr. Ed, like we're treating the symptoms and going from there.
Great. Well, thank you both. We're a couple minutes after. Yeah, Martha, were you?
Yeah, so I just want to mention really quick, later today, everyone's going to be receiving a follow-up email that will have the links to the recordings, both English and Spanish, the evaluation links, both English and Spanish, and then any other resources. So you will be receiving that from me later today. And I also wanted to thank Dr. Zerwesti, Dr. Solis for joining us today. And a huge thanks to our presenter, to our translators, who, thanks to them, we could hear this in Spanish. So thank you, everyone. I don't know if Jill, you have something else to add or if you're good. All right. Thank you, everybody. Have a wonderful day. And yeah, we'll see you soon. Thanks.
Thank you.